Imagine paying thousands of dollars for this sci-fi laser treatment, right? Something that promises to literally reverse cellular aging,
Right.
only to find out that the doctor's main proof that it actually worked is just them asking you, so do you feel better?
Yeah, that's a wild realization for a lot of people.
It really is, because we usually expect modern medicine to operate with this absolute engineering level of precision. I mean, you break a bone, the x-ray shows that jagged white line, and there's just no debate.
Exactly. It's objective.
Right. But step into the landscape of women's health and aging, and suddenly that diagnostic precision can get, well, remarkably blurry. So today, we're taking a massive stack of medical guidelines, clinical trial protocols, and research papers to explore a really fascinating intersection. We're looking at the clash between microscopic biology and high-tech medical devices.
And to you, the listener joining us on this deep dive, whether you're prepping for a medical meeting, catching up on women's health tech, or you're just insanely curious.
Which is a great reason to be here.
Totally. Our mission today is to give you the exact aha moments you need from these sources without, all the overwhelming information overload.
Okay, let's unpack this. Our focus today is on a condition called genitourinary syndrome of menopause, or GSM. And specifically, we're looking at how a relatively simple microscopic cell swab called the Vaginal Maturation Index, or VMI, is acting as this crucial, entirely objective truth teller before patients undergo these controversial, very new energy-based device treatments like lasers.
Because there is a booming multi-million-dollar market right now for so-called vaginal rejuvenation.
Oh, massive.
Yeah.
And we want to clear a path through the medical jargon to figure out how clinicians actually mathematically prove what works.
Right. And if we connect this to the bigger picture, before we can even begin to evaluate the efficacy of a laser, we have to look at the underlying physiological condition they're actually trying to treat.
Right, the baseline problem.
Exactly. We have to look at why GSM has historically been so incredibly difficult to measure objectively.
Yeah, I was looking at how the medical community defines GSM in the literature, and it used to just be called vulvovaginal atrophy, right?
Yeah, that was the old term.
But that newer GSM terminology seems to capture this really massive cascading drop in estrogen much better. What exactly is happening to the tissue architecture when that systemic estrogen just disappears?
Well, the shift in terminology was vital because, the estrogen receptors aren't just in one localized spot. They're densely packed throughout the entire genitourinary tract.
Oh, okay.
So when a patient goes through menopause and those estrogen levels drop off a cliff, the tissue undergoes profound structural changes. It thins out dramatically, it loses its inherent elasticity, and the vascularity, like the blood flow to the area, just decreases.
Wow.
Yeah, so the tissue becomes dry, it gets fragile, and it's highly prone to inflammation.
And that biological shift is what triggers that severe cascade of GSM symptoms we see in the clinical data. We're talking about chronic dryness, burning, dyspareunia, which is painful sex, and those persistent urinary issues like dysuria or recurring UTIs.
Exactly. It's a chronic condition that can severely impact quality of life. But diagnosing the severity of it, it isn't straightforward at all.
Not at all. Because for decades, clinical trials and day-to-day diagnostics have relied heavily on highly subjective measures, right?
Yeah, the primary benchmark has long been this most bothersome symptom approach, or MBS. The clinician basically just asks the patient to identify their single most severe symptom and rate it on a scale from mild to severe.
Which, I mean, obviously has value in a clinical setting because patient experience matters. You want to know how the patient feels.
Ugh.
But relying entirely on how a patient feels to measure actual cellular health, that seems incredibly problematic for research.
It introduces a massive variable of subjective interpretation, like what's severe to one person is mild to another. So to try and offset that, clinicians also use the Vaginal Health Index, or VHI. This is a visual physical exam where the doctor scores the tissue on a scale of 1 to 5.
Okay, based on what?
Things like elasticity, fluid volume, pH, and epithelial integrity. And if the total score drops under 15, it indicates atrophy.
But still, relying on a patient's symptoms or doing a visual VHI check without taking a microscopic swab, it's basically like trying to diagnose a dying car engine just by listening to the rattle.
That's a really good way to put it.
Right. Like, something is mechanically failing, the mechanic can hear the friction, but until you plug in that diagnostic computer, you don't actually know what the internal microchips are doing. We need a mathematical, objective look at the tissue. If symptoms are subjective, how do we get that mathematical look?
Well, that brings us to the diagnostic computer for the tissue, the Vaginal Maturation Index smear, the VMI. This is the gold standard for objectivity because it entirely removes human feeling and visual guesswork from the equation.
I really want to get into the mechanics of this because the cellular biology here is just fascinating.
It really is.
So the VMI smear is taken by gently scraping the upper lateral third of the vaginal wall. But what are we actually looking for when we put those exfoliated cells under a microscope?
What's fascinating here is that the VMI provides a direct visual readout of the body's estrogen environment. The epithelial lining is made up of three main types of cells.
Okay.
And by looking at the ratio of these three cells in a single smear, a pathologist can mathematically determine the exact level of estrogen stimulation happening right there at the tissue level.
Okay, let's break down that cellular timeline. The first type you see in the smear are the parabasal cells, right?
Yep, the parabasal cells.
These are the immature cells, and visually the sources describe them as small and round, but they're dominated by a massive nucleus. Like the nucleus takes up something like 50 to 70% of the entire cell volume.
Yeah, that visual of the massive nucleus is the key indicator of an absolute absence of estrogen stimulation. These parabasal cells are essentially just stuck in a holding pattern.
I want to push on that for a second because this is where biology gets really cool to me. Why is the nucleus so huge in an immature cell? And why does it physically shrink as the cell gets exposed to estrogen? Like, what's actually happening inside that cell?
It comes down to cellular differentiation and function. So a parabasal cell is closer to a stem cell. It's active at the DNA level, just waiting for hormonal instructions.
Gotcha.
Its nucleus is large because the chromatin, the genetic material, is loosely packed and actively being transcribed. But when estrogen hits that cell, it triggers maturation.
Oh, so it gives it a job.
Exactly. The cell's primary job shifts from just waiting to actually providing a structural barrier. And to do that, the cell body swells up with cytoplasm, specifically stockpiling a sugar called glycogen.
So it's basically filling up its cargo hold with sugar.
Yes. And as it fills with glycogen and keratin to become this tough, mature barrier cell, the nucleus is no longer needed for all that active transcription. So the nucleus shrinks.
Oh, wow.
Yeah, it condenses down into a tiny, dense dot in a process called pinosis.
That makes so much sense. So if there is zero estrogen in this system, the cell never gets the signal to fill up its cargo hold. It just stays small with a giant active nucleus, and that's the parabasal cell.
Exactly. Then, moving up the timeline, the second type is the intermediate cell. These are somewhat mature, the nucleus has started to shrink, but they're influenced more by progesterone than by estrogen.
Okay. And then we reach the final stage, the superficial cells.
Right. These are the fully mature cells. Under the microscope, they look completely different from the parabasal ones. They're large, flat, rectangular cells with abundant cytoplasm full of that glycogen.
And the tiny nucleus, right?
Yeah, those tiny little pinotic nuclei that only take up 10 to 20% of the cell. Seeing a field of superficial cells means the tissue is highly stimulated by estrogen.
So we have this amazing visual evidence, but the VMI takes it a step further by turning that visual into an actual mathematical equation. The pathologist actually calculates a maturation value.
They do. They take a random sampling of 100 exfoliated cells from the smear. They literally count them and assign point values based on maturity.
Wait, they manually count 100 cells?
They do. A fully mature superficial cell gets 1 point. An intermediate cell gets about half a point. The exact formula can use 0.5 or 0.6. And an immature parabasal cell gets a tiny fraction, usually 0.2, or in some indices it just gets a 0.
Wow. So you run the numbers on those 100 cells, and you get a definitive score from 0 to 100.
Right. And if the resulting score is 49 or lower, it indicates 0 to very little estrogen effect, which is the classic presentation of GSM in menopause.
And a higher score.
A score of 65 to 100 indicates a highly estrogenic environment, typically seen in younger women during their fertile years.
Now, here's where it gets really interesting. When I was digging through the clinical trial protocols, I found a detail about the VMI that completely reframes how accessible this can be. Getting this highly objective microscopic math doesn't even necessarily require a physician wielding a speculum.
The University of Pittsburgh self-collection study. Yeah, that data is incredibly compelling.
It really is. The researchers took 20 midlife women and gave them instructions to perform the swabs themselves, like just self-collecting from the vaginal walls. Afterwards, physicians performed a traditional speculum exam and took their own control swabs. The correlation between the self-collected samples and the physician-collected samples was 0.97.
That is near perfect statistical match. I mean, it proves the cellular data is robust regardless of who wields the swab.
And the patient feedback was overwhelmingly positive. 95% of the women found the self-swab very easy to do, and 80% explicitly stated they preferred self-collection.
Which is completely understandable.
Right. It really highlights how this highly objective metric could be deployed widely in clinical trials without all these invasive procedures.
It does raise an important question, though. The VMI gives us the cellular math, but to get a truly complete objective picture of GSM, we have to look at the immediate environment those cells are living in.
Ah, the pH.
Exactly. That brings us to vaginal pH, which is the other crucial objective marker.
Because pH is a core component of that vaginal health index we talked about earlier. But how exactly does the acidity of the tissue tie back into the estrogen timeline we just mapped out?
Well, it's this elegant, interconnected ecosystem. Remember how we discussed estrogen causing the superficial cells to fill their cargo holds with glycogen?
To sugar stockpile, yeah.
Right. That glycogen is the primary food source for the local microbiome, specifically a dominant genus of bacteria called lactobacillus.
Okay.
As the superficial cells naturally shed into the vaginal canal, the lactobacillus consume the glycogen, and the byproduct of that bacterial feast is lactic acid.
Oh, I see. So a healthy estrogen-fed environment literally creates its own acid supply.
That's exactly it. That lactic acid keeps the healthy premenopausal vaginal pH low, usually between 3.8 and 4.5. But in menopause, the estrogen drops.
Which means the superficial cells disappear.
Yep. And if the superficial cells disappear, the glycogen disappears. Without the food source, the lactobacillus population crashes.
So no bacteria, no lactic acid.
Exactly. And the pH rises above 5, it becomes more alkaline. So a pH over 5 is an undeniable objective chemical flag for GSM, working right in tandem with the VMI smear.
Okay, so we've established the diagnostic baseline here. We have the subjective MBS symptom scores based on patient experience, and we have the objective truth tellers, the VMI cell math, and the pH strip.
Right.
Now we can finally apply this to the high-tech treatments flooding the market, because with these microscopic tools, we can actually test the wild claims being made by device manufacturers.
We really can. And the landscape of energy-based devices, or EBDs, has just exploded over the last decade.
Oh, completely. We're talking about transvaginal lasers, fractional CO2 lasers, erbium YAG lasers, and microablative radiofrequency. The marketing for these devices is ubiquitous right now.
It's everywhere.
But what are they actually doing when they're inserted into the tissue? Like, what is the biological mechanism of a laser treating a lack of estrogen? That sounds crazy.
It sounds sci-fi for sure. The mechanism relies on a targeted physiological stress response. These devices emit energy waves, either light or radio frequency, designed to heat the connected tissue of the vaginal wall to a very specific temperature range. Exactly 40 to 42 degrees Celsius.
Wait, 42 Celsius? That's about 104 to 107 degrees Fahrenheit.
All right.
That is a significant localized fever. Why 42 degrees? What happens at that specific threshold?
Well, the intention is to induce what's clinically termed controlled thermal injury. At 40 to 42 degrees, the tissue doesn't just passively warm up. The heat actually causes microscopic proteins to slightly unfold or denature.
Unfold. Oh, wow.
Yeah, and this triggers a massive cellular panic response. The body detects the thermal injury and immediately synthesizes heat shock proteins.
Okay, so it's essentially tricking the body into a state of emergency repair.
That's exactly the mechanism. Those heat shock proteins activate tissue growth factors. The body rushes fibroblasts to the injured area, which stimulates neocollagenesis.
Which is the creation of brand new collagen fibers, right?
Precisely. It also triggers vascularization, growing new blood vessels, and it forces the epithelial layer to remodel itself.
See, the clinical promise here is massive. These devices are being heavily marketed for vaginal rejuvenation, claiming to resolve laxity, stress urinary incontinence, and the entire spectrum of GSM symptoms.
They're promising a lot.
Yeah, they're promising to restore tissue elasticity and moisture, theoretically completely bypassing the need for systemic or topical hormonal therapies.
And, I mean, the appeal of a hormone-free solution is undeniable. Patients who have a history of, say, estrogen receptor-positive breast cancer, they often cannot use traditional estrogen creams.
Yeah.
But for them, a localized mechanical solution like a laser sounds like an absolute medical breakthrough.
But the medical community is fiercely divided on whether these lasers actually achieve that breakthrough safely and effectively. And this is exactly where the VMI smear becomes the ultimate referee in a really high-stakes clinical debate.
It is. The controversy surrounding EBDs is one of the most prominent debates in modern gynecology right now. In 2018, the FDA issued an unusually strong public warning regarding the deceptive marketing of these energy-based devices.
A public warning.
Yeah, they explicitly called out manufacturers for promoting vaginal rejuvenation without sufficient clinical evidence.
And the major medical societies backed up that skepticism, too. I mean, the joint guidelines from the American Urological Association, SUFU, and AUGS, they state point blank that the current body of evidence does not support the use of CO2, ERYIG, or radiofrequency for treating GSM symptoms.
Yeah, they were very clear on that.
They officially classify these laser treatments as experimental, outside of an institutional review board-approved clinical trial. But I have to ask, why is the medical establishment pushing back so hard if the mechanism of action, the heat shock proteins and the neocollagenesis, if all that makes physiological sense on paper?
Well, the pushback exists because the vast majority of early observational studies on these lasers relied almost entirely on those subjective measures we discussed earlier.
Oh, the MBS scores.
Exactly. They relied on the most bothersome symptom scores. They asked patients who were paying thousands of dollars out of pocket, do you feel better?
Oh, wow. The placebo effect in that scenario has to be astronomically high. I mean, when you undergo an expensive high-tech intervention with a literal laser, you are highly primed to report improvement.
Totally. And that compromises the integrity of the data. If a trial relies solely on MBS or a clinician's visual assessment, it is dangerously susceptible to bias. You cannot definitively prove that the thermal injury actually triggered the biological remodeling that the marketing claims it does.
So what does this all mean for our diagnostic computer? How does the VMI cut through that placebo effect?
To resolve this controversy and establish true efficacy, the FDA proposed a rigorous gold standard for any new GSM treatment.
Okay.
A successful trial must demonstrate 3 concurrent endpoints: a statistically significant improvement in the most bothersome symptom, an objective decrease in vaginal pH, AND, an objective shift in the maturation index.
It's the baseline imperative. This is why taking a VMI smear before the laser is even turned on is absolutely critical to the science.
Precisely. Consider the protocol of a rigorous clinical trial. A patient enrolls, and before any intervention happens, a VMI smear is taken. The pathologist calculates a baseline maturation value.
Let's say it's a 30.
Right, a 30, which shows a field dominated by immature parabasal cells with those large nuclei. Then the patient undergoes the standard protocol, which is typically 3 laser sessions spaced out over 14 weeks.
And following the treatment, you swab the exact same lateral wall.
Yes. If the laser genuinely remodeled the tissue, if the neocollagenesis and vascularization actually matured the epithelial layer without estrogen, the microscope will show a literal mathematical shift.
So you'll actually see the difference in the cells.
You will count fewer parabasal cells and a significantly higher percentage of mature superficial cells with those tiny pinodic nuclei.
And if the math doesn't change, the tissue didn't change, no matter how good the patient feels. Without that baseline VMI smear, the entire experiment is just expensive guesswork.
Exactly. Now, we should note that while the broader medical guidelines maintain the experimental classification pending long-term safety data, there are rigorous trials utilizing the VMI that have produced notable results.
Right, like the 2019 Politano trial.
Yes, that's a prime example of a randomized, blinded clinical trial that adhered to these objective metrics.
What were the parameters of that specific trial?
The researchers directly compared the efficacy of fractional CO2 laser treatments against traditional topical estrogen cream and against a baseline standard water-based lubricant, and they rigorously tracked the Vaginal Health Index and the VMI scores across the cohorts.
And the microscopic math showed what?
The data showed statistically significant improvements in total vaginal health scores from baseline to week 14 in both the laser cohort and the estrogen cream cohort, outperforming the standard lubricant.
Oh, wow. So under the microscope, the laser held its own against actual hormonal intervention, and they were able to mathematically prove it using the VMI.
Right. The data in that specific trial suggest biological efficacy, yes.
Yeah.
But the FDA and major societies are still waiting on comprehensive, long-term safety profiles regarding repeated thermal injury over years, which is why the guidelines remain cautious.
Sure.
Our goal isn't to declare the lasers definitively good or bad. The crucial takeaway is that the VMI is the impartial metric being utilized to eventually settle this multi-million-dollar debate.
It is the ultimate lie detector test for the device industry. A microscopic epithelial cell does not know if you're in a clinical trial, it doesn't know what the marketing brochure said, and it certainly doesn't know how much the treatment cost.
No, it doesn't.
It only responds to the physical, biological environment it exists in.
It strips away all the noise and provides the raw data necessary for evidence-based medicine.
Let's bring this all together. We started with the very silent, structurally profound impact of systemic estrogen loss in menopause. We zoomed all the way down into the microscopic world, examining how a cell's nucleus shrinks as it fills with glycogen, mapping out the difference between parabasal and superficial cells. And then we zoomed all the way out to the multi-million-dollar industry of transvaginal lasers, utilizing 42-degree thermal injury to force tissue regeneration. Ultimately, through all the flashy marketing and medical controversy, it is the humble, inexpensive VMI swab taken before treatment that keeps the high-tech science honest.
Understanding that distinction is incredibly empowering. We navigate a healthcare landscape that is just saturated with aggressive marketing. Recognizing the difference between subjective symptom relief, which is important but vulnerable to placebo, and objective, mathematically proven cellular change is the cornerstone of critical thinking.
Absolutely.
It equips you, the patient or the clinician, to ask better questions. When presented with a new device, you can ask, where is the objective evidence? What did the VMI show?
It's the difference between a mechanic just listening to a rattle and actually running the diagnostic code. And that leads me to a final thought I want to leave you with, something to mull over long after this deep dive ends. We've spent the last few minutes exploring how controlled thermal injury from a laser can trigger heat-shock proteins to potentially mimic the tissue remodeling effects of estrogen, completely bypassing the endocrine system. If we can trigger cellular maturation and reverse a hormone-driven aging process in the vaginal tissue just by precisely tricking the cells with 42 degrees of heat, what other hormone-dependent aging processes throughout the human body might eventually be hacked or reversed using nothing but perfectly targeted thermal energy?
The biomechanical implications of that are staggering.
They really are. Thank you for joining us on this deep dive into your customized sources. Until next time, keep asking the hard questions.